All right, good morning, everyone. Welcome to Health Talk. I'm Peter Christian, John King over there. Good morning, John.
Good morning, Peter.
Joining us in the studio, Dr. Stephen Tahta at the Community Medical Center. Today, we're going to talk about lung cancer, right?
Yes. Thanks for having me.
Actually. Welcome
Both
back,
Peter and John.
Yeah, welcome back.
Thank you.
So, for those who weren't with us the last time you were here, could you just give us a little bit of a bio? Tell us about yourself.
Yeah. I'm a cardiothoracic surgeon, so that's a heart and lung surgeon for the most part. I do a few other things as well, but I got to Montana in 1999. I did my training in Canada, finished my training in 99.
They have the same basic anatomy up there.
Yeah, it's almost the same. That's right.
It's colder, though.
It's remarkable how it transfers to the United States.
Does the blood flow like maple syrup up there?
I get a lot of maple syrup jokes. However, now I'm American, so... Okay. You can't really pick on me for being Canadian anymore.
That's right. That's right. So
I worked at St. Pat's for many years, and for the last 4 years, I've been over at Community Medical Center, starting their thoracic surgery service line.
So why cardiac and thoracic surgery? Both pretty complicated parts of the body. Why not just specialize in one?
It's a really good question. In fact, slowly for some programs, it's moved that way. So in other words, you specialize as a cardiac surgeon or you specialize as a thoracic surgeon. The old guys like me, we all trained in all of it. In fact, some of us trained as well in vascular surgery as well, although our board certification is in heart and lung surgery.
Well, one would think the heart and the lungs are right there together, and when one affects one, it might affect something else, right?
Actually, that's very true. That's very true in some cases. For the most part, at least from the clinical practice of a cardiac or thoracic surgeon, they're different problems.
Okay.
But there's an overlap.
And so one of the things I was talking about with you before the show started was we're watching my kids play soccer. I kind of get involved during the game. But while we were watching the soccer game, I noticed there's that new building near the western flank of the community campus there. And I asked my wife, she said it was the new cancer center.
Right.
Do you work in there at all?
Yeah, I work over there as well. We are trying actually to bring together the physicians that take care of cancer patients in more of a team approach. And some of those things we've done, we talk about patients as a multidisciplinary committee. But I'm going to move my lung nodule clinic from my office in Building 3 over to the cancer center here very shortly.
So it'll be more of a one-stop shop for
yeah, exactly.
everything.
That's the whole idea, and we'll take care of our lung cancer patients over at the cancer center, whether it's surgery they need or chemotherapy. It'll be there.
So cancer sufferers that are in extreme where they actually live in the hospital. Do they live in
stage 4? Things like that.
Do they live in the cancer center?
No. So if you need to be admitted, you'll end up being admitted to the hospital, the community medical center. It's an outpatient service, basically. But radiation therapy takes place there. Infusion for chemotherapy takes place there. Minor little surgeries we actually do in a procedure room there. But otherwise, the rest is done over at the hospital.
Now, please forgive me, but what do you consider minor surgery when it comes to thoracic and heart surgery?
Let
me going to reach in there for a second and flip the switch.
So I'll give you two common examples.
Okay.
One is in order to give a patient chemotherapy, sometimes it becomes difficult to find veins, to deliver it intravenously.
You have to put a port in.
Yeah, exactly.
So I'm that guy because I have ninja veins. They dodge the needle and slip around. Apparently,
you probably still have good veins because you're young. But we put a port in that gives reliable access, to the bloodstream for chemotherapy, for blood tests. We have to put the ports in over at the hospital, but we can take the ports out right in the cancer center. And then the other thing is for certain types of cancer, if you need a bone marrow biopsy, that can be done over at the cancer center. So those are two of the common little procedures that we do there.
How prevalent is lung cancer? We've talked a lot, because because of breast cancer awareness and the Pink Game and all the things that's going on with the Susan G. Komen Foundation.
Right.
But lung cancer, the fight against lung cancer has been going on ever since people realized what danger cigarettes offer. The Surgeon General came out in the 60s. What is the status of lung cancer in Missoula? Is it rising? Is it in stasis, or is it declining? What?
Because we have a small population, I would say that for the most part it's stable. Now, if you look at larger populations like the whole country, because we are seeing a decline in smoking, and we saw that first in men compared to women. But because we're seeing that decline now for many years, we have started to see a decline in lung cancer rates, which is great. It's good news. The women are expected to follow the same curve as men. So men hit the peak of the incidence of lung cancer, are now on the way down. And women are still at that peak, but we expect that to come down too.
Well, there's a big difference between casually smoking to not smoking at all, right? Far as so, when you have more and more people not smoking at all, you're going to have, it seems to me, in a generation or so, a big jump down from incidence in lung cancer.
I have thought the same thing. Is that when we move away from the baby boomers, we may see an even bigger decline.
Are the majority of your lung cancer patients that come in, are they usually like over the age of 45 or 50, or are they all ages?
Yeah, they can be all ages. I mean, I've seen some devastating cancer patients as early as in their 30s, but that's highly unusual, and even 40s is unusual. It starts more commonly in the 50s.
I know you're not a veterinarian, but you see those those commercials where the secondhand smoke's affecting your pets, and the dogs and cats are getting. Yeah. Obviously, not talking about pets right now, but have you ever diagnosed lung cancer in children because of secondary causes from smoking?
No, actually, another good question, because there are pediatric cancers that affect the lung, but the lung cancer that we're talking about, we don't see it in children.
Even if there's secondhand smoke in the room?
Well, I mean, for one thing, it's hard to prove causality, right? So if there's secondhand smoke and a child grew up that way, and then in their 40s they get lung cancer, the question is, was it related to secondhand smoke? If there's a genetic predisposition, if a grandfather had lung cancer, that's probably the more likely source.
I'm going to tell you, when we come back, I'm going to tell you just a quick story about how my father realized he had lung cancer. And in his story, when we come back, if you don't mind, I can share that with you.
No, I'd love to
by
hear
the way,
it.
our lines are open, 721-1290. Both my mother and father died from lung cancer, by the way. So 721-1290 is our number, 1-800-568-5309. We're coming right back. We'd love to talk with Dr. Stephen Tahta from Community Medical Center. We'll be right back. And we are back on Health Talk. 721-1290 is our number, Dr. Stephen Tahta. Just real quickly, I want to share my dad's story. He was a Marine, joined when he was 16, started smoking immediately. he was a three theater veteran, World War II, Korea, and Vietnam. Smoked the whole time, right? And it wasn't until he retired and got really, really ill with the flu. And he was literally bedridden for 3 weeks, could barely walk. It was a horrible case of the flu. When he woke up, he walked into his closet and came out with his eyes watering. And he asked my stepmom, he said, "What is that stench?" Because he hadn't been able to smoke.
Yeah, right.
And she said, "That's your clothes. You always smell like that." And he was a very fastidious man,
Yeah.
And he said, "You mean I always smell like that?" She go, "Yep."
Yeah.
So he took all of his cigarettes, a man who had smoked for 50 years, flushed them down the toilet, and never had another one.
Yeah, good for him.
But he was in his late 50s at the time.
Right.
And within 3 or 4 years, discovered he had lung cancer, and eventually that's how he passed away.
Right.
And the same with my mom. So we were talking a little bit about what happens with people who don't smoke but who live in an environment where there's lots of smoke.
Yeah, we still consider that not high risk. So if you just divide simply patients into high risk and not high risk, low or moderate risk. That secondhand smoke does not put you in the high risk category.
Does it put you into the moderate category?
Well, that's it. It's a judgment call. Could it be a significant amount of exposure that puts you at moderate risk? It's a bit of a judgment call.
Gotcha. I'm really curious about when it comes to lung cancer. Lungs are my childlike imagination of these anyway. It's like
let's hear this.
It's like a bunch of empty bags.
Okay.
Right? Inside two really big bags. Okay. So you got lots of surface area, in other words.
Right.
Where cancer could hide.
Yep.
And so it seems to me extremely difficult to know if you've got cancer. I mean, with like breast cancer, you might be able to feel something different.
Right.
Or a skin cancer, you might be able to see it.
Right.
But with lung cancer, with all these inside, little surface areas and compartments, it'd be impossible for you to know you had it without some kind of X-ray or science vision.
Right, and that's always my main message. Especially talking to the public. Lung cancer hides in the early stages. Most patients are asymptomatic, and yet for lung cancer in particular, the treatment in early stage lung cancer is so much more successful than in late stage. In fact, if you divide it into two, the first two stages and the second two stages, the second two were unable to cure lung cancer, whereas in the first two stages, there's a chance for cure.
So I want to talk to you a little bit about something that it's kind of worrisome about the way that we pay for medical care in America, right? So using Peter as an example, during the break we were talking about, he grew up, his parents both, did they both get lung cancer?
Yes.
They both smoked heavily. They smoked heavily around him. He didn't really smoke. Maybe when he was a kid, he played with it or something.
I didn't have to.
He didn't inhale. So a guy like Peter grows up. He's not a smoker, but he was exposed to lots of smoke as a child. So, his health insurance isn't going to really cover him for getting a test. If he wants to go and pay to get a test, can he do that?
He can.
And what's the price range for getting yourself checked out?
So the nice thing about this is that before the insurance companies covered low-dose CAT scanning, and anyone who happened to listen last time, we talked about how screening with a chest X-ray is no good. Screening with a low-dose CAT scan, so much better. And before the insurance companies covered that low-dose CAT scan, we started our program at Community Medical Center. So I worked with the radiologists. They were absolutely great. They understood the importance of the program, and we brought the cost of that test down to about $280, I believe was the price. Now most patients are being covered, but if you came to see me and said, this is my situation, and we talked about some of the other risks besides smoking, and there's a concern, then we would go ahead and screen.
Let me just share just one more quick thing in a personal experience, because I watched this happen to my dad. Okay, he had lung cancer, and when he was in his mid to late 70s, they decided they had to take out one lobe of one of his lungs because it was really severely affected.
Right.
So they went through that surgery, and because of that, he was not getting sufficient oxygen, and it exacerbated the Alzheimer's that was just beginning. Okay. And so because he couldn't breathe, his brain was not getting enough oxygen, again, which exacerbated the problem, and rapidly he declined after the Alzheimer's was. And I was thinking, if he hadn't had that surgery and had his full lung function, he might have lived quite a bit longer. But I don't know that.
Yeah, once you get into mixing diseases or comorbidities, as we call it, it becomes much more difficult to understand.
Sure.
His oxygen levels probably, if they were too low, it was treated with oxygen, and maybe he was on oxygen.
Sure, but he was being a proud guy. He wouldn't walk around with his oxygen bottle, that kind of thing. So,
Right.
Yeah.
Yeah, it just gets it gets much more difficult when you start bringing in other disease states.
Yeah.
Yeah.
So when you deal with the lungs, I mean, do you notice a preference for where cancer starts? Left lung, right lung? Is it different in every person?
It's different. There are some types of lung cancer that have a tendency to be more what we call central, but the usual lung cancer that we see most of the time, and there's two types, can be anywhere. So when I say central, if you imagine the heart in the middle of the chest and the lungs on either side, the lungs are like a mushroom. So they have a stalk, and the airway and the blood vessels are in the stalk, and then the whole cap of the mushroom is the lung.
A mushroom of plastic bags.
Yes, exactly. Okay. Not plastic, but bags. Remove the word plastic.
Okay.
I removed the word plastic when you removed the
word. And if you want to be really smart, call them alveoli.
Okay.
They're little alveoli.
He was my 7th grade science teacher.
My wife will slap me for talking like Trump if I'm not careful.
Okay, we're going to take a break. Come right back. We'll be alveoli. That's a sportscaster name. Anyway, we're going to come right back with more of Health Talk in a moment. And we're back. This is Health Talk. Dr. Stephen Tahta joining us this morning. We're talking about lung cancer, and just real quickly, some basics. What is lung cancer? What does it do to the lung?
So the simplest way I can answer that question is that cancer cells are abnormal. They're not like our normal cells. They multiply way faster. They have a completely different morphology or makeup. Lung cancer starts when one of our cells becomes an abnormal cell and then starts to multiply. The effect on the lung, especially if we catch it early, there may be a small little lesion or what we call a nodule in the lung. That is the result of this thing growing. The effect on the lung can sometimes be none, and that's why so many patients early on are asymptomatic.
Now, you had mentioned earlier there are 3 types that you dealt with. One that was more towards the center, the other 2 more towards the periphery of the lungs. All of these end up having the same kind of detrimental effects to us? Or?
Well, yes, there's actually 4 types, but there's one particular type that can be central more than the others. But the key to these 4 types is how successfully can we treat them. So there's one in particular that is extremely difficult to treat, to control it, to get rid of it. It's very difficult, and luckily that one is the least common.
And do you have names for these cancers? I mean, even the flu virus has H1N1 different strains. How do you?
So the 2 common types are adenocarcinoma and squamous cell carcinoma. And you might recognize those 2 names because there are other parts of the body where you can get those types of cancer. And then the other 2 are small cell and large cell. Small cell is the difficult one. Yeah.
Wow.
All right. So we have exactly 2 minutes left in the program, Dr. Tahta. So what should we look for to think of, oh my gosh, I want to get screened?
Well, it still boils down to a smoking history, not secondhand exposure, but actually a smoking history. And there are criteria for that, meaning not everybody who smokes actually falls into the high-risk category, and we screen only the high-risk patients. So if you smoked 3 cigarettes a day, for the last 40 years, you actually don't necessarily fall into a high-risk category, believe it or not. Now, some of us are a little bit frustrated by that because the picture is more complex, like we talked about with your father, and your mother had lung cancer, you have a family history. The story is a little bit more complex, and so the screening parameters are not ideal yet, but it's a move in the right direction.
So if you smoke 3 a day and both of your parents had lung cancer, would you say go get a screening? And would the insurance company say go get a screening?
The insurance company would say no screening. Now, if you come and see me and we talk about it, I have made on occasion exceptions.
Okay, we've got about 30 seconds here, so give us some contact information. How do we find you?
Sure.
How do we make an appointment? How long do we have to wait for an appointment? That sort of thing.
the wait is pretty short. We try very, very hard to get patients in the next week or the week after, no matter how busy the clinic is. The office number is 327-3819, 327-3819, and that's how it starts.
Great. Dr. Tahta, thanks for being with us.
Thank you.
A fountain
Appreciate
of information as always. We appreciate it.
Thanks.
And thanks for putting up with our horrible humor.
You made me laugh. That's a good thing.
I'm thinking about alveoli the rest of the day. We'll be back with Talkback. Stay with us.